Thank you very much for the invitation, and it's great to see so many friends here. So I'm going to cover a little bit of where we are today in terms of the value proposition, particularly with robotics, because you've heard about some of the other computer-based technologies, but we can easily see where the future is going from that perspective, and I'm happy to expand either in questions or thereafter at the end. My disclosures here are very, very important because in the hip here, particularly in robotics, one technology has stepped well ahead in time of the others, so I'm going to be focusing on our data and the data of others on Mako, so you will have to take everything I say with a pinch of salt. I think you all aim with your preservation and your replacement surgery to have happy and active patients, but the bar here is increasingly being raised by our patients who don't just want to be pain-free, they want to be active, they frankly just want to be normal. And our surgery needs to be able to meet that bar, whatever we are doing. We've deluded ourselves a little in that we had the operation of the last century. We have a fantastic procedure, the legacy of some great minds that we can deliver to hundreds of thousands of patients worldwide. But although it is a tremendous procedure with a huge effect size, in reality, there are still problems. There's still instability, there's still leg length inequality. Some patients, much more than you imagine, still have pain. There is dissatisfaction, and there are unmet expectations. So there is more to do for us to get hip arthroplasty as good as it can be. Now, that's not just me giving you that as an argument. There is lots of data out there if you happen to look for it and don't put your head in the sand to say patients still have pain after hip replacement. But perhaps the most objective data is if you look at our national PROMS program and how well our hip replacements are doing in the UK, only 44% are actually excellent. That means over half actually don't think it's excellent, and 13% don't think they're much better after their hip replacement. So there is definitely an issue here that we can deal with. Some of it will be psychosocial, but some of it will be technical and surgical. So we need to look at that. And part of that, and part of the thesis of all the presentations you've heard, is getting biomechanics right, putting the hip where the hip belongs. That's offset, that's version, that's inclination, and I think we're beginning to grasp this afternoon that that's of the whole couple, not just the individual components. The orthopedic literature is full of papers looking at the acetabulum and ignoring the fact there is a femur connected to it below, and those days should now be behind us, whatever technology you're using. The other metric is impingement. We haven't focused enough on impingement in arthroplasty as opposed to in preservation, and avoiding impingement probably has something to be said for it. Now, robotics, and that's what I'm going to focus on, is more than navigation. It's not just a visual guidance system. It is a delivery tool as well. It is the modern robotics is an active, constrained, haptic tool. You have a CT, you have a plan, and then the surgeon is in control but defines the boundaries of where you deliver the implant. This is very different from RoboDoc, which is the old device. And I mention that specifically because that device is still around in North America, not so much in Europe, but also it fills all the systematic reviews. I'm going to give you the one systematic review that covers modern robotics later on, but those who misguidedly quote systematic reviews of robotics in the hip to tell you that it does not work essentially are misquoting, misguiding, because they are looking at old literature with old devices. What we're looking at now is a preoperative CT with CT acquisition, and I love the Mayo idea of going 2D to 3D. I want you to bear in mind that right now that's a futuristic AI concept. The current models of 2D to 3D have no data and no evidence. They're marketing tools. Most surgeons using 2D to 3D in the knee abandon that and use other techniques instead. So we look at CT, we have sitting and standing radiographs to look at the lumbar spine. We get a preoperative plan, both for the cup and the stem. We expose, we register, and then we prepare on both sides, and then insert, considering the relationship between the two. The workflow is relatively straightforward. There are pins in the pelvis, as you saw earlier. We register and do the femur first, and that's in order to understand femoral version, offset, length, and adjust on the acetabular side if we need to, and then we deliver the coupling as we go along. And you can do that for simple cases, you can do that for more complex cases. The reality is that what you get on your plan is what you deliver during the operation. So you stop worrying about your post-op radiographs. We're also, as you heard earlier, starting to understand the hip-spine relationship a lot better and the importance of that to the individualized target for each and every patient. So sagittal balance becomes very important, and as I already said, impingement becomes key, and the software now actually allows you to look at impingement and alter implant position in order to avoid impingement. If this video works, it will show you a little bit of the power of this technology and what you can do. So the plan is delivered to you. You can visualize your socket position in any plane that you want. You can ensure it's covered anteriorly. You can ensure it's deep enough. You can ensure that you are happy with your center of rotation. Once you are comfortable with that and you know where you want your center of rotation to be, you will then proceed to inputting your spinopelvic parameters. So your sacral slope, your pelvic tilt will come into the equation, and then you can look at where your femur is going to be and start looking at whether you are going to impinge or not. You have a clear femoral plan. Right now, the robot does not prepare the femur for you. That is the future without doubt. But if you know what size you're going to put in on the plan, you will know whether you've got there or not, and whether you need to adjust your varus or valgus, very much as Klaus was suggesting. You then proceed to model. You have your femur in place. You have your socket in place. You can determine if you are seeing any impingement or not. The red mark is impingement, at which point you will then look at your parameters. Are you impinging on implant? Are you impinging on bone? And thereafter adjust what you are doing in order to get that into a non-impingement situation for that patient. The converse, of course, if you cannot get a non-impingement situation for that patient, that may be the indication for dual mobility in a primary scenario. At the same time, you're looking at offset, you're looking at length, and therefore you can adjust your operation to get it where you want. Now, the perceived advantages of this are 3D planning, good bone preparation that's accurate and precise, and functional positioning, this concept that you put the implants in the position for that patient. I think the future is that all the data we will get from this will inevitably give us the chance to do real predictive analytics. If we recognize the phenotype of that patient, that hip, we will be able to predict what needs to happen to do a successful outcome. That's where really big data is going to come in. And of course, it's a phenomenal education tool in terms of planning and delivering. I'll go over our data quickly. We've published a great deal of it. We know from our data that it improves accuracy and precision in terms of getting the acetabulum where we want it, and we also know that the learning curve is short. Randomized study, which has been running, was delayed by COVID, is now recruited, and essentially we were trying to compare plans that were the same delivered by a robot or delivered by a surgical team to see what happened and where we landed up, looking at a number of metrics, both radiographic and clinical. The primary outcome was radiographic, being able to hit the target. The one-year clinical data will be available later this year. But we looked at all the secondary parameters you would expect, and we have Andres Fontalis doing his PhD on the cost effectiveness, the health economics of this, because that's going to be key in a country like the UK. So this study's fully recruited to these first two arms. The subsequent two arms have also just finished recruiting in the last month, so we've got it with the VROM software and without. The early data suggests cases are similar as you would expect in a randomized study. If you look at the radiographic metrics there, the robotic group was more accurate in every single dimension you looked at. So in terms of hitting a target, there's no question this is better. We've replicated what others have done. The adverse events are there for you to see. There's nothing specific there. They're typical hip replacement complications, nothing that has been increased by using this technology or the pins. So the story so far from this randomized study is that there's better accuracy in restoring native center of rotation, better preservation of combined offset and leg length, but there are still unanswered questions whether this is just something statistical. Will it bear out clinically? We'll have the clinical data for 1 year for this cohort later on this year, and we'll have the later cohort with spinopelvic adjustment to see if that makes a bigger difference. So watch this space. From the UK, we've also got the RACER study. That's a pragmatic, multi-center study that Peter Wall's running with Ed Davis that is going to tell us robotic versus non-robotic in hands all over the country, whether there is a difference in forgotten joint score or not. That will be very interesting. That's almost a third of the way to recruiting now, so we will have data from that within the next couple of years. There's no doubt that the move from craftsmanship to systematic planning and execution is upon us. That is the future. That's what we need to do. People are now applying this to complex cases. So if you imagine the tricky DDH Crow 4 or the post-acetabular fracture case, they're nice scenarios. You can imagine the future will be revisions. We're already there with the software. It's just getting it out there to use it. Nick Clement's shown improved forgotten joint scores in a non-randomized study in Scotland, and they've replicated the idea in their systematic review that Harris hip score, leg length inequality, correction, and acetabular position were all better with the robots. The learning curve is frankly much, much lower. Not so much of a problem. It is, in our hands, 12 cases, in different hands, a little bit longer if you haven't navigated before, but the learning curve is time. It's not harm. Patients do well straight away. Some North American big data, lower mechanical complications, lower instability, but potentially higher costs, and that's going to be the equation we all have to grapple with. The big news, and you heard a little bit of an inkling, but nowhere near as powerful with other technologies earlier, is the fourfold reduction in instability. 2 major studies here illustrating a dramatic reduction in instability when this technology is used. That's a huge message. No RCT is going to deliver these numbers, but both HSS and Detroit have shown that actually it can reduce the risk of instability in your patient population hugely. Is it cost effective? I think Ben Dome's work suggests that in a high volume center it is. Likewise, Nick Clement's work, very much the same. If you do it in a high volume unit, then it probably is cost effective. That's something we're going to see from our RCTs and study. So what is the value proposition at the moment? I think we know that manual hips are not as happy as people think they are. I think we also all recognize that biomechanics matter, and we don't reproduce them anywhere near as well as we would like manually. Robotic hips definitely deliver your target better, and I would say to you now we have enough data to say that they lead to less instability. The unknowns, or the perhaps unknowns, are that we're not entirely sure of the target for every patient, but we think it helps because we can simulate and deliver an impingement-free zone. We don't know if it delivers better PROMs. We have an inkling from Nick Clement's work. We'll let you know what the RCTs show later this year. And we're not sure about cost effectiveness. That will depend on your healthcare system. We're studying it in the most tricky economic system in the UK. So again, our data may feed into it. But the really big problem here, and I think it's all positive, the future is really cool if you're a hip replacement surgeon, you like enhanced technology and you're not putting your head in the sand. But all these other devices that are coming out, and there should be many more, including augmented reality and so on, all need to be evaluated in the same way. I've shown you studies, I've shown you future studies. There's a lot of work behind this one device, and all the others will need to do the same because you cannot translate from one to the other. So in conclusion, I think computer-assisted hip replacement has found its time. The results are encouraging, positioning is accurate and reproducible. We're starting to understand this concept of functional hip positioning, dealing with pelvic alignment issues, with spinopelvic issues. We're avoiding impingement. There are some good studies out there, and I think big data and AI will have a big role to play here in future, but beware the secondary devices. They are very welcome. We need them, but they need to be evaluated in the same way. Thank you very much.